The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Welcome to today's Open Mind Circle Elite Executive Roundtable, Smart Living, Innovative Approaches in IDD Support, the LADD case study. I'm Stacy Fox with the Open Minds Market Intelligence team, and I'd like to introduce Brian Hart, Chief Strategy Officer for LADD, Living Arrangements for the Developmentally Disabled. Brian Hart is the Chief Strategy Officer for LADD, a Cincinnati nonprofit serving adults with developmental disabilities. He's made it his mission to push the boundaries of what options exist for adults with disabilities. He is never satisfied and believes there is always a better way to increase independence of others and break down the systemic barriers that hold them back. Brian has been on the forefront of expanding services through the use of technology-enabled supports and community clusters of service. Today's session is moderated by Ray Wolf, who brings over 40 years of experience in the health and human service sector to the Open Minds team. His area of expertise include managed care and value-based reimbursement models, financial analysis and management, mergers and acquisitions, CCBHC certification, integrated care, performance improvement, and strategic planning. Before joining Open Minds, Mr. Wolf served in a 22-year tenure with Pittsburgh Mercy Health Systems in Pittsburgh, Pennsylvania, and most recently served as the organization's Chief Operating Officer, where he was responsible for oversight of all system operations, strategic planning, and performance management. Before we get started, just a few housekeeping reminders. Your audio will be muted during today's briefing. However, we do encourage you to submit any questions you have through the question box, and we will present them at the end. The slides and recording from today's brief will be available on the Open Minds website tomorrow. Ray, I will turn it over to you.
Thank you, Stacy. Today is such an exciting day for this event. This is probably, to me, one of the most powerful presentations that I've seen in our area. You know, in terms of IDD, one of the struggles we all have strategically is what will happen with the residential homes. On one hand, nothing can be more important to the people we serve than lodging and food. But on the other hand, the cost pressures from our payers are making that incredibly difficult. Frankly, the lifestyle that happens in many IDD homes is not as self-determined or self-actualized as we would like. And the recent staffing crisis has just spread through those homes like the COVID virus. We're looking at vacancy rates in 20 and 30%. We're looking at staff who are doing so much in overtime that there are real questions about burnout that are developing from that. So what are the answers? Where do we go from here? One of the quick and easy words is simply to snap your fingers and say technology. But what does that mean? And can you give us a concrete example of how that would work? Well, Brian has been doing that for 3 years. The LADD case study in Cincinnati is an absolutely remarkable study of how very basic, very simple, relatively inexpensive technology can create an enormous change in the cost of care, the satisfaction of care, the impacts that we all see. So without further ado on that, Brian, I'll let you move forward with your presentation.
Well, thank you so much. And it really is, this is one of those areas that I'm excited to have an opportunity to share with this group, because when we look at technology and think about how are we using technology to change the way we deliver services, a lot of times I get stuck in my own bubble, right? I feel like it's working really well for me. I can see the outcomes, I can see how it's working, but is anyone else really interested? And when I see that there's so many people that have shown up, then it makes me realize, okay, other people are excited about this opportunity as well. And so I just want to talk a little bit about what we have at LADD, and we call it beyond the concept phase. And the reason we say that is because when we first entered into this project a few years ago, we looked across the country to find other models of how you could really use technology to not just be a piece of assistive component for somebody, to not just be an augment to service, but really, how can we change the way we deliver service? And what we heard all the time was, well, it's still in our concept phase. I would see, deck after deck after deck of presentation slides of what we hoped it would one day be. I've been to smart homes where no one was actually living there yet. And we decided that we were going to buck the system, and from day one, our project was going to, day in and day out, involve the individuals we serve. So we like to say that we're beyond our concept phase, that we are deep into our work, and I'm excited to share that today. So just a little bit about who LADD is, because a little bit of credibility behind who we are is always important. So like Ray said, we're a provider in Cincinnati that's been around for 46 years, founded by parents of adults with disabilities. Not unique to our founding as it is in other states and other metropolitan areas across the country, that back then parents wanted their kids to be more independent, so they founded organizations like us to do that. Since then, we've grown to serve over 600 people in the Cincinnati region, and we came to the same realization that Ray was describing, that we want to serve more people, but there's really not enough funding, and even if there was enough funding, there's not enough staff to do it. And knowing that the staffing crisis is not going to change, we thought as an agency, we need to do something better. We can't just wait for the system to change itself. We can't wait for a rate increase every couple of years of 25 cents was not going to solve it. We knew that we had to be relentless. We knew that we had to look at our current system and see how could we better work within it? How could we change it? How could we find those who were the ones managing our system and get them to understand that a new way is possible and a better way is possible? And with all of this in mind, always going back to the idea that those that we work with, the individuals that we support, are the ones that are going to define the way that we provide this service and the way that we change. So many times in my work, we've looked at how do we solve for a staffing crisis? How do we provide better service? And we think about how do we do that through the lens of the staff that provide it, or the executives that oversee the agency, or the funding sources. And rarely do we look at the individual's experience. And how do we take what they're looking for and build the system around that? And so that's our philosophy. That's how we innovate. It's why we innovate. We are, like I said, we're relentless. It's an exhausting path to go down, but it's also very exciting because each day we're seeing better and better models that are coming out of our work. We're seeing that it's actually providing more independence. And as we go through, you're going to see this. One of the questions we get asked all the time, though, and we get asked less and less, this is why now? During COVID, we pushed harder and faster than we did before COVID because we had unique opportunities where people were more open to technology. But these areas, these 6 areas that I identify here on this slide, really show things that are pretty clear across the country. Current needs are unmet. I know that in Ohio, there's at least 40,000 people who are waiting for services that we know of. We got to assume that there's probably 20 to 30,000 that we don't know that need services. We know that the service model that we've had for decades is super inefficient. We know that if the idea that when we bring someone into services, the way we decide what they're going to receive is based around when they're home versus what they actually need is horribly inefficient. We know that our staff want to be better. They want to be more efficient, but the system sometimes isn't set up for it. It's broken. We know in some states the wait list has gotten so long they just eliminate it. That happened in Ohio. They said, we're just not going to have a wait list anymore. That way we don't have to worry about a wait list. But that doesn't mean people don't still need service. And then the staff shortages and turnover continues to grow. We found through this model that I'm going to describe that our turnover, which already wasn't too bad, has gone down significantly. And our staff shortages have decreased exponentially to a point where our vacancy rate is around 8 to 10% versus the nation average of 20 to 30%. And that is because when you use technology as the first mechanism of service delivery, you don't just have to have bodies sitting around waiting for things to happen. So that's what smart living really is. It's a new way of delivering service. It's thinking of how we deliver services from a technology-first mindset. When I first was introduced to LADD and was contemplating moving from where I had been living in Utah to Cincinnati to work and run this program with LADD, I was informed that we were a technology-first state. And so well, that sounds great. What does that actually mean? How does that work in terms of funding, in terms of resources, in terms of rule modification? And what I really found out is that as great as Ohio is with technology, when they say they're technology first, it was because a governor, one administration ago, wrote it down and declared it, but it didn't catch on. It didn't actually go anywhere. And so smart living is our method where we really do truly look at technology first, and then we deliver services. It's a combination of smart home technology, wearable technology, so people can have technology in their community, using staff more efficiently, and then making sure that supports are in place that when somebody moves from a typical support system to a virtual or technology-enabled support system, they don't lose anything that they would normally have. So the system is either the same or better than it was before. So our model, we're in the middle of a 3-year pilot. We're about to start our 3rd year and of people actually living in the service and receiving it. And again, like I said, it includes these areas, but it also includes what we call our forever home model. And this is where to ensure that people live in their community to where they can live as independently as possible. We use a model that's a lot of single family homes, all in what we call walkable neighborhoods. You know, if you have sidewalks that actually lead somewhere, people's independence goes up. The houses are all within close proximity to each other, but none of them are like on the same block or in the same cul-de-sac. We're not buying a huge piece of property and putting 25 homes on it and then saying, look, everyone's living in the community. Our model is that people should just be a part of their community. And then looking at, once we have that, a team-based model of service delivery that's focused more on outcomes than someone just showing up and delivering service. What we found is that as we use technology to deliver services in the first manner, we don't need staff as often. And we also can use the technology to solve for all those, well, what if this happens, or how can we interact with that? The staff that are coming into the home are much more efficient. They're value add. They're focused on their outcomes as they go in. Some of the outcomes around our pilot that we're working on is a pilot is only as good as the research that's derived from it. And so we are working closely with Xavier University with their School of Occupational Therapy to do research on this project. And we're starting to get some of those results as the school year ends and data is getting published. We're finding that the return on investment of the technology that they're studying is pretty great. We're finding that for our clusters of homes, changing the way we deliver services saves the system hundreds of thousands of dollars per cluster. We also find that each piece of technology has a much quicker ROI than we would have ever thought. A smart refrigerator, for example, used correctly, has an ROI of about 10 weeks. You think about how impactful that can be for someone for a piece of technology that 3 years ago nobody thought would actually provide a valuable service. The other thing we're looking at is results on impact and independence. So if we have a typical model where staff are there 24/7 and we pull physical staff out and now it's remote staff available 24/7, intervention staff as needed, what does the independence level of the individual look like? And we're finding that the independence is going exponentially up. That as we've reduced, hundreds of hours a week in support services in different locations, the level of independence of the individuals is skyrocketing. People are taking control of their own lives in a way that we've never seen before. The other outcome that we're looking for is when we think about technology, a lot of it is focused around a house. And so we talk a lot about smart homes, and we do a lot of our work in smart homes. But what happens if somebody actually wants to leave a home? We want people out of their house. We want them a part of their community. And so a means that we can take all the technology that works great in a home setting and have it go with someone when they leave the house and their outcome that we've been working on. And then the last area is an alternative service model. So we know that even in the most efficient system that we can build, there are still going to be tens of thousands of people per state who will never qualify to get waiver services or government subsidized services. And so those individuals who probably can't afford round-the-clock care at tens of thousands of dollars a month still need some level of support. We are building out a private pay model that is affordable to middle class, so that for less than $1,000 a month, an individual could live independently, could have all the technology they need to support them, could have supports virtually and interventions in person as needed, and really give them a full life. We've been doing that program and that test for about a year now, and we're finding it's highly successful. Individuals are moving out of their parents' basement that they never thought was possible. People are living on their own and leaving group homes for the first time they never thought was possible. So it's really exciting. And really at the end of the day, and I work in Ohio, so I'm going to talk about Ohio a lot, but I've worked in other states. So it's not, I don't believe that anything that's happening in Ohio is unique to Ohio, but it's significant savings. We know that increased self-sufficiency is on the rise, but it's also decreasing the reliance on publicly funded supervision. It's not just saying, okay, if someone walks through the door, we're going to pay them. It's really looking at how do we change. So what we did is we looked at this and thought we need to find a method where we can move from traditional services to a technology-first model. When I talk about traditional services, I mean the type of services we've all provided for 40 years, where we bring someone in, we figure out when they're home, we staff them to be there when they're home, and whatever happens, the staff has to deal with. And that model works sometimes, it doesn't work sometimes so great. You think about myself, I'll use an example. When I provided that entry-level DSP, direct support professional work, depending on the day, I was either saw as a really great provider or terrible. Because when I'm working with someone, I'm not as interested in how their home looks, what their hygiene looks like, if they've done their laundry. I'm way more focused on getting them out in the community, making sure they have employment and those kind of things. So if you're judging my service delivery on what their house looks like, I'm going to look like a terrible DSP. If you're judging it on the way they're connected to their community and what their quality of life outside their home looks like, I would be great. But unfortunately, what we do is we have DSPs that just show up and they're scheduled from 8 to 12 or 8 to 4 or whatever it may be, and they're responsible for everything that happens. And so we really needed to change that model because we don't have enough staff to do it. There's not enough funds to do it. And we need to have technology with staff that are trained in multiple areas provide this different level of service. And so our model is not unique to, to any kind of change. We identify our solution, develop a plan for it, implement our plan, and then build ways to scale it. And so that's the method I'm going to follow as we go through this. But identifying, when we first started looking at this, we thought, how do we even begin? And as you're thinking about if you're an agency provider or a funding source, you're probably thinking the same thing. How do I even begin down this road? And so what we did is we partnered with, again, Xavier University's occupational therapy program, experts in our field who've done service delivery for decades, and looked at what are the needs of an individual who's receiving services. This is a spreadsheet. It's a snapshot of a spreadsheet. If you can't read it, that's fine. You shouldn't really be able to read it. It just gives you a representation of how much data is on per page and how many pages exist. And what this is this sheet tells us what are all of the needs of somebody who's receiving services and what is being delivered by a DSP. What is everything that someone needs to live independently, either with or without support. And then we took these items and looked at who's already doing this. So what other areas are already providing this type of service? Who's providing remote supports? Who's providing oral hygiene? Who's providing health and medicine management? And then we looked at what technology solutions exist for each of these needs. And what we found is that for every need we could come up with, almost all of them had some sort of technology solution available for it. The problem is the platforms to connect all of these services were not readily available. And so when we did our analysis, we found that for someone to live fully independently, a DSP provides service in 308 total areas. Out of those 308, 184 of those are what we call our must-have needs. Those are things that if we don't have a good solution for those needs, we have no business pulling out our in-person DSP staff. 75 of those needs are things that we should have that just make us provide service at a higher level. And then 39 are those things that are nice to have. Those are things like a robot vacuum, which doesn't, you can live independently with a robot without a robot vacuum. But if you have 4 20-year-old guys living in a house together, it's really nice to have something like that because the house is going to be trashed. And so then we looked at finding platform technology providers who could help us start connecting these dots. So we spent almost a year looking at 23 different technology provider options to build a base to start connecting all these technologies. What we found is that as you're looking at this field, there's a lack of integrated solution, meaning that for all of these different pieces of technology, most of them do not talk or connect with each other. We also found that there's a complete lack of DD focus. Even when we look at health devices or different communication devices, the idea that someone with a disability may be using it to be more independent was almost never thought of. We also have found that most are a lot of startup providers that will be there for a while and then they just disappear. I can't tell you how many pieces of technology I started using and worked really well just to find out it's not going to actually go anywhere. So we had to vet through that. And then we found that really one platform provider was ready to begin the groundwork on. And then we worked with them to build a new system. They started with aging. We built a disability platform that starts connecting all of those dots. And what we found is that out of those 308 items, 89% of those have an identified solution. So out of 308, 85% of those we've identified a way to solve with technology. Out of those 184 must-have solutions, the things that we absolutely must have, 99% of those have a really viable working solution. The areas that we're still struggling with and still working through are areas around medication administration and fall detection. Now, thankfully, that technology has come a long way in the last few years. So we are working with a few different manufacturers around devices around those things. And hopefully that will shore up that last little 1%. But to give you an idea of how do we look at someone and what they need, we developed an assessment that gives us an idea of what someone's needs are. And so when you're looking at this screen, this is not telling you how many of these things we have in total, but this is showing you how many things one individual we serve has identified needs for. And so our program, when we begin with an individual, we start with an assessment process that starts really high level to just look at it and say, is this person a good fit for a technology first service, or are they more of a traditional type service person? And what we find in looking at our population and a few populations in surrounding areas around us, that about 40 to 45% of those we serve are really good candidates for a technology first way of delivering services. Now that number shouldn't discourage anyone, because anywhere we can save on funding or staffing in any area, so out of 45%, all of those resources get funneled into those that still receive traditional services. Because every time I go through these presentations, there's always people that are thinking, well, that sounds good for you, but it won't work for this person I support, or won't work for this group home that I have. And you're probably right. If you can identify people it won't work for, that's true. But think about other people you serve and think about who it would serve. And for those that, we have a few people that need round-the-clock care. Any area where I can be more efficient using technology for those that don't need round-the-clock care frees up my staff to be in a place where they're actually providing value. So we start with that assessment. The next one we look at is we go through and looking at the needs of the individual. It's an assessment we developed with our OT team that looks at what is important for the individual, what are their needs, what are their skills. It's not like all of our typical assessments we've done in this field where we try to find all the things they can't do and that's what staff can do for them. What we look at is what are they good at, what are they able to do, what do they need assistance in, and how do we support what their needs are, what their desires are, what their wants are, and where are those gaps. We take this list and then we compare it with that technology list we have and start building out a technology package for everyone, and a tech fitting package. And that brings us to what this sheet would look like. So for communication, this individual has 6 requirements. For home monitoring, they have 14. External monitoring, we have 2. For daily routines, this person has 16 different requirements. It doesn't mean necessarily that they have 16 devices that built into that. It could be done by 1 or a few, but they have 16 requirements that we need to solve for. Once we're done with that, there's always a little bucket left over that is not solved with technology. And those are the areas where our integrated support specialist, which is our new position that we created, they go in and provide service. So what we've done in this area is we've eliminated our direct support professional and our lead professionals and our house managers and all this level of bureaucracy. And we have a lean geographic team. They cover 3 houses that are in a close geographical area, 12 individuals. It's a team of 5. And you think about those 5 people, what they do is they are focused on what are those things technology can't solve for, and that's what they provide support for. So they go in, they provide a very needed specific value-add support, and then they leave because they're not scheduled for 8 hours. They're scheduled to provide a service. And then the remote support team that's monitoring anywhere between 1 to 20 or 1 to 30, depending on the situation, they're providing all the other wraparound monitoring and support that's needed. What this allows us to do is that using this model, we typically need 18 DSPs to cover a 3-house cluster for round-the-clock care. Again, we can do it with 5. And you think about all those people that can then be reallocated somewhere else. And that's where, and I should have got to this slide before I talk about the browse right next, is looking at this elimination of block time caregiving. So we don't look at someone, and we'll say Matt, for example, and say, well, Matt has a job, but he's home from 3 p.m. to 8 a.m. the next morning, so we just need staff there in case that happens. Instead, we say Matt is being solved with technology. The technology is monitoring him and assisting him at home or in the community or at his job, wherever it's needed. And then he has 4 items per week that he works on with a staff member. And they're going to work with him around his schedule to schedule when that value time support is happening. Again, this is really specialized. We're able to pay those people more because there's less of them. And really, they're providing a value-add service like we've never seen in our field. And then we started, so now that we've identified everything we're going to do, then we start implementing. And again, our key elements are really around our smart living homes and our wearable technology, and then our remote and technology-enabled support. And I want to talk a little bit about a smart home. And so when we built our first smart home, we built it from the ground up. We installed all the technology after it was built. That way we would know every place where we would have to put a cord, put a screw in the wall, move a wire. but it also gave us the ability that we never have to build a home from the ground up and install technology. We can retrofit technology anywhere because most of the technology is done with Wi-Fi, with Bluetooth, with batteries, with double-sided tape. And so when we talk about smart homes, you don't have to think about a home that's specialized and built specifically for technology. We provide the smart home technology service in homes that we have built or renovated, homes that individuals have lived in their whole lives, apartments, people that are living with their parents still. We have 3 small group homes that have 6 individuals in them. We provide support services to them. They're kind of an aging model group we're working with. And so that's where smart technology really can change that every home could be a smart home. And then our wearable technology. How do we look at all the different pieces of wearable technology that we have and connect it with our staff so people can be independent in the community? And then looking at remote supports and thinking about the way we look at remote supports. So our remote support and technology-enabled support system that we use is not based around, okay, this door opened or this person pushed a button, now we're going to call someone out to either show up or call them back. It's really based around trying to be as smart as a DSP would be in the home and as proactive in the support delivery. So if we have an individual who is using a sensory room technology to calm down, and they use this sensory technology 3 times in a morning, it's going to alert the staff that someone's trying to calm down, and whatever tools they have are currently not working. Let's intervene and see what's going on. And so the staff will reach out and try other techniques. We're not waiting for a hole in the wall or a fight between roommates because someone can't calm down. We also have individuals who will get up and have unique eating disorders or may have unique things around cooking and food. The staff can intervene and provide supports before the fridge opens in the middle of the night. They can talk with someone about middle of the night eating or eating the wrong foods, things like that. And the idea is to be as predictive as possible, just the staff would be as if they were in the home. So it's not glorified life alert. We're not waiting for a call to come in. We do respond if a call comes in, but most often the staff there's assigned to a specific group of people, just like a DSP would be. They know their individual plans. They know the individuals. The system with the rules and the way it's set up gives us more feedback on how to provide support, but it's not a call center waiting for things to come in. Another area that we looked at this project is how do we get the right criteria of individual? So we looked at 4 young men for our first project who had a variety of disability to give us the biggest sample. We have autism, Down syndrome, a hearing impairment, a verbal impairment, a strong vision impairment, legally blind, I guess is a better way of saying it, so that we can know as we build this technology out, we know that if someone doesn't speak, Alexa doesn't work real well if you don't talk to it. So we need to have touch technology. But if someone has a visual impairment, using touch technology doesn't really work. So you need that voice technology. Or if someone has a hearing impairment, verbal alerts or audible alerts won't work. So different light sensors may be a better fit. And that's been able to give us our plan where we started with 4, we expanded to 20 after the first month, we're now up to 50, and we each continue to grow as we build. Into our home, our smart living home, which is where we first started, we're a little over 18 months now into our program. During that time, we've eliminated over 100 hours per week of in-person staff time. I want you to take a minute and think about that. Think about any situation where you might have someone providing service, and if you could take 100 hours a week where it truly is not value-add service and put it somewhere where you desperately need it, how just impactful and changing that could be for your service system. I mean, I talk with agencies all over the country all the time, and I know there are CEOs out there working grave shifts because the system is inefficient. Think if we could take that time away and leadership could be focused on leading and not focused on just covering shifts. We're partnering with a lot of health companies on smart devices in this home. So we're looking at companies with Oral-B, with Priya, with Stanley Health, with Hero, with different things to find out which health technologies can we use to have someone be better independent. One cool thing that we've had for an individual who lives in a 4-person house is he has had round-the-clock staff because he takes insulin. And he's in one of those scenarios where what he's either eating or not eating, his sliding scale is different. And so he needs to take a glucose monitor, look at that, look at his sliding scale, compare it to what he's eaten or not, and then decide how much insulin to give based on that scale. This person can do it independently, but also has number dyslexia. So having this whole system has not really worked for him independently. So he is someone who has been thought he had to have round-the-clock staff. And that's really the only thing they had staff for. He literally does not need staff for almost anything else except for safety and security. So through technology, we can have Bluetooth and web-enabled glucometers that the staff, when it's time to take his glucose reading, the glucose monitor gives us the reading, the remote staff. They also have the sliding scale and the schedule, so they know how much to draw. He can draw his insulin independently, so they can look at it, make sure he has the right amount, monitor him, giving himself his insulin, and there we go. And so now this individual who typically has round-the-clock staff really only gets staffing and in-person interventions a couple hours every few days because he doesn't really need it. He doesn't want it. He works independently in the community, and he expresses how grateful he is for his independence and his freedom. He used to complain constantly that he was sick of having people in his house, and now he doesn't have to have that. And so that's really what this is about. A few other successes are a smart shoe insole is something that I think is such a basic piece of technology that can really change someone's life. We have an individual who's in his 50s, and those of us that are in this, any kind of field of service delivery know the term of no alone time in the community. When it's not safe, we've decided as a provider or an agency, it's not safe for them to be alone in the community. And so this individual was given that designation at a very young age. And so for the last 50 years of his life, someone has been with him every minute of his life when he leaves his house. And he is someone who was tagged a loafer or a runner who would run away. And when we started talking to him about it and asking, we were curious and just wanted to ask more questions, he would say, he just tells us, I want to just go on a walk alone. I like to be outdoors. I like to be alone. But what we found is that he would get lost. He wouldn't know when to come back for appointments. And he maybe would venture into parts of town that weren't safe or a place where he shouldn't be, like a rail yard or something like that. And so we tried different wearable technology. We started with a smartwatch, and he hated wearing a watch. We tried a phone, and he was really sold on his flip phone and refused to move to a smartphone. And so we found some smart shoe technology. It's a little chip that goes in his shoe, and we're alerted if he breaks a geofence or goes somewhere he's not supposed to go, or is not safe for him, I guess is more how I should describe it. Or if he's going for a walk, we'll talk to him and say, hey, you should be back, in about 45 minutes. If he's not back, we can look and see where he's at, and staff can call him on his, really smart flip phone, which is not smart at all, and talk to him about it. But for the first time in this guy's life, he's just going on walks alone. And not only is he just going on a walk, now he's going and walking to friends' houses and having social engagement or going to different areas where he never would have thought possible. And so this is different areas that we can look at using different technologies paired together with staffing systems, remote supports to change the way people receive services. Another one that, like I said, the smart refrigerator is a huge one. When we first built the smart home, we got a smart fridge because we thought, well, we have to have that. It will look weird if we don't. We never really knew if it would be impactful. And so we worked with the state of Ohio. We got a grant to study it. And what we found is that the ROI on a smart fridge is 10 weeks, and that we're saving anywhere between 12 and 15 hours a week in staff intervention based around what a smart fridge actually does. So the individuals that work with the smart fridge, they meal plan on their own. They build their recipes. The recipes help build the grocery list. The groceries are sent to the grocery store. The groceries are either ready for pickup or delivery. It walks them through how to prepare the meals. When they're done and put leftovers in the fridge, it tracks when they're put in the fridge. It alerts them when it's time to throw them out. Staff can look remotely at what's in the fridge to help them plan for meals that were unexpected. Just really changing the way people interact with their food, but also, again, giving that control back to the individuals. Because so many times when staff are shopping for food, preparing meals, we try to do it in the most meaningful way that the person may want, but we still have the bias of the staff that's providing it. So when we take that away, give the control back to the individual, it changes the way they interact with that technology. And so that's all fine and good, and it's working really well, but where are some of the gaps? And some of the gaps that I always like to talk about are integration. So integration is one that as new technology comes out, we have to find a way to integrate it with everything else we're using so that we're not using 5 different computer screens and 4 different tablets to monitor everything that's going on. When we first started, that's exactly what we were doing. And we found things that either maybe we don't have to monitor it all the time, and we can use lagging data, or we can start connecting the dots of different technology. We've had to build software that actually connects technologies together so that when a sensor goes off, a camera can pop up and let us know if someone needs to be looked at, or when a blood pressure monitor comes in, if it's out of range, it can tell the staff what they should do next. But that's an area that we're still working on. Customization of needs is one as well. Everyone's different, so everyone needs different technology. When we looked at how we were going to deliver some technology-based supports, we thought we could either build a technology package that everyone just has to use, or we could do it the way we did, where we just find the technologies that work, make sure they all make sense, make sure they work well, make sure they connect, and then we look at what the individual needs, and that's their technology package. So each person has a little bit different technology. We also try out all these different technologies. We were trying to find a smart toothbrush, for example. I was the one tasked with finding which one was best. So I found 32 smart toothbrushes. You probably didn't think there were 32 different types, ranging everything from a child Colgate one from the grocery store to something that my doctor had to loan me from a DME provider. And we tried them out. We tried them. How would it work for the individual? How would this be meaningful for them? How would they interact with it? How would staff provide data and intervention based on this information? And then what we find is the one from Target, from Oral-B, is the best one. It gives us an app that the individual can watch as they brush their teeth, that coaches them. It also gives us data that lets us know how well are they brushing their teeth, how long do they brush their teeth, which teeth are they actually brushing, which ones they aren't. So that instead of having staff stand there twice a day and trying to coach someone to be brushing their teeth, we can take this data, we can work with someone, maybe a dental assistant or another provider, a healthcare provider, to say, hey, this person's brushing is not working. Can you give them an intervention and coach them on it? And that data is actually meaningful because we know it's actually working. And that toothbrush works really well for almost all of our population. We have some individuals where that doesn't work well for them because it could be they have a physical or a visual or a verbal impairment or a physical impairment where that doesn't work. So we could try something else off the shelf. That's what customization is. We try to go as far as we can, but we know there are just still some things we can't solve for. Transportation is also a huge barrier. We know that the big three barriers to providing more services, there's not enough staff, there's not enough money, and transportation is hard because most people don't drive. And so we're looking at how do we expand and use technology for transportation. We're using it now with our wearable technology to help monitor transit routes, to use them to safely walk around in communities, to call Uber, things like that. Autonomous vehicles is also another area that we're looking at. So today, as luck would have it, I'm visiting a company that works with autonomous vehicles to see, could we use fixed autonomous shuttles to solve for this technology? It's one of those things that we are never stopping in our pursuit of how do we help people be more independent? How do we help build and grow this system? The last area that's a huge gap is buy-in. So this all sounds really great as we're talking about it, but how do we ensure that families, individuals we support, funding sources really buy into this model, because it's really drastically changing? And how do we explain to a family member whose child has lived in a group home for 30 years that we're going to have them move into the community or even stay in the group home, and instead of having staff in their home 24 hours a day, they're only going to be there when they're actually needed and providing service. But that virtual and technology-enabled staff will still be there 24 hours a day. It's hard to change that mindset. So my advice or expertise to share on that one is start talking about it now. We know that as we serve a younger and younger population that have grown up with technology, it's going to be easier, but that's really where we're at. Now that we've implemented our program, though, how do we scale it? And what we really first looked at is, as we thought about all the technology and scalability, how do we know where to add our value-added in-person supports? And so our intervention support specialists, these are the kind of the 10 areas that we find we have a lot of overlap in that aren't solved with technology. And to really scale, we need to understand how many people do we need in person, how many supports should we provide. So things around healthy eating, like we can do a lot virtually, but if you need someone that wants to meal prep, you need someone to come in and teach you how to cut your food, how to prepare meals. Because it's really easy to buy an Alexa-enabled microwave that you scan the barcode, it cooks the microwavable food, and you just eat frozen dinners for the rest of your life. That's easy and it's fine, it works, but it's not healthy. And so healthy eating requires work, and we want people to be healthy. Roommate and social relationships, when someone lives in a setting where they have staff there around the clock, either knowingly or unknowingly, staff are intervening and helping manage those social and roommate relationships. Now that the staff aren't there in person, how do we teach people to do that? How do we coach them through that? Social connections, employment, all these different areas. That's how we continue to scale this out, by knowing what supports we have to provide support in. And then how do we change our model around staffing and a community? So instead of saying that we have someone assigned to a house, they're assigned to a cluster of homes. Like I said, we have three homes in a cluster. All of these clusters are within 5 minutes of all the houses are within 5 minutes of driving each other. There's always going to be a staff close by. The other thing we looked at is, how do we change the mindset of these teams? So they're not just showing up and doing whatever is needed, they're targeted on what they're doing. And so we're looking at changing from a structure where they are assigned tasks, they go and do a task where it needs to happen, to these teams are self-managed. They know the people they're working with. They know the neighborhoods they're working in. We give them the parameters. As leadership, we're the architects of what they do, but not the directors of what they do. As long as they stay within the bounds, they're good to go. If they need coaching because they're going out of the bounds, that's where we help. And really, as we start with this technology-first assessment of needs and then build out through there, it really changes the way that people want to deliver services too. They're happier, they're enjoying the work they're doing, and they're really looking at outcomes now. We're not just looking at, okay, I guess we're there, we'll see how it works, and whatever happens, happens. In Ohio, we're on a pay-per-quarter-hour service model. So right now, when we walk through a door, we get paid. We need to change that service model to say, let's focus it on outcomes. Let's base it around what are we actually delivering, not just if someone's showing up and walking through the door. And that's where people that are doing remote monitoring question, well, what's different about smart living in your model? And a lot of things overlap, like emergency response time is the same, customized supports can be the same, sensors to trigger interventions can be the same, but then it goes deeper into health and wellness, behavior intervention, because we're trying to be proactive, a corresponding staffing model, outcome-based service delivery, trained employees that are providing actual service, not just answering the phone to triage what needs to be done next. And so when somebody interacts with someone, they know them. It's not just a call sheet where it pulls up and says, okay, you have so-and-so calling, here's their need, deal with it and move on to the next person. The last area that we've looked at is this is working really well for what we're doing here at LADD, but we provide services in Cincinnati in one county. It's not a huge area. It doesn't cover the whole rest of the country. So if this is working well for us, how do we help it work well with other people? And so we've been working very closely with Xavier University's Occupational Therapy Department to develop a toolkit that we'll be able to share with other agencies, be able to come in and provide that technical assistance, provide our expertise, so that you don't have to go and do a capital campaign for $1.5 million to learn what $300,000 for the technology you're never going to use, how to connect all the dots, how to build a staffing model. So we'd be able to share that with you so the system can continue to grow. As someone who has worked in this field for a long time, I still remember, and those who have heard me speak before have heard this anecdote before, but I remember my very first day, I got into this work because I was sick of working in my corporate job. And so I went to the nonprofit sector. I found this disability services director job. I had no idea what disability services were, but I was willing to learn and willing to give back and willing to have a job that was meaningful. And I still remember that first day where the CEO sat me down in this company and explained, here are all the things we want to do. We want to do this, we want to do this. But right now we're in kind of a staffing crunch. It's a little staffing crisis we're dealing with. As soon as we get over this hump of staffing, we're going to do all these great things. And so that was almost 15 years ago. And as it turns out, we never got over that hump. It never went away. It got bigger. It's not going away. And so I truly believe that if we don't change the way in which we deliver services and the way we think about how we deliver services for a large number of our population, our service sector will no longer exist because we just won't have enough people to do it. And using technology has really helped us change this way we do it. Right now, like I said, we have very few openings, and the openings that we have are some of it's administrative, but in our direct service, there's not as many because we don't need as many people to provide the service. Also, when our staff members are providing value-add interactions every time they're in someone's home, their job satisfaction is so much greater. Not only are we able to pay them more, but they actually feel valued. You know, how often are we going into the homes of people we support and the staff are watching TV with someone or working on homework or texting or just staring at the wall waiting for something to happen? And they're not enjoying that. They would rather be doing something meaningful. So that change is really impactful too. And we've had the data's coming back, and we're finding, like I said, that the cost of service is lower. We know that we need less staff to provide for more services. We're continuing to add more and more people that we serve every week. And I know in other parts of Ohio and other parts of the country, people are turning people away or discontinuing services because they just don't have the staff to do it. Whereas we're able to continue to add houses. I have 2 houses right now that are about to be done being remodeled. 8 people with a devote, and then we're going to move on to the next 3 houses. And because of the staffing model, we're able to do that. We also had a really cool experience where I've been touting the success of what we've done for a long time, and our state, our division, DODD, they call it here, had their data people run their numbers to see if it actually was meaningful. And so across all of our acuity rates and our level of need, we found that using a technology-first model is lower cost, meaning that there's more money to provide services, more money to the provider, more money to pay people, but the outcomes are actually higher as well. There's a pretty direct correlation that as the cost goes down using technology, the level of independence of the individual goes up. And that's what it's really all about. And so all this information is something that we're looking to share, that those of you that are like, this sounds really great and I want to start, that's what we're working on. Our toolkit, we had a plan when we first started that we'll do a 3-year pilot, we'll develop a toolkit, and then if anyone ever wants to use it, we'll help them out. We did not realize that COVID was going to happen. We didn't realize the staffing crisis was going to be whatever comes after crisis or emergency or catastrophe. There's something else that we're in now. We didn't realize there'd be that much need. So we've shortened our timeline. By the end of this year, it will be ready to go and be able to start sharing some of that information. But until that point, start looking at ways where you could make a change, looking at ways where you could look at the individuals that you're serving and change them. A few other successes that I think are really cool to share. We have an individual who, in the transportation world, had been taken everywhere by staff or his mom his entire life. And he never had really independence on where he wanted to go in the community because he was limited to what was his mom's schedule. And with his staff, what did his roommates also want to do? Because if one person wants to go somewhere, but 3 people want to go somewhere else, and you have 1 staff member, someone's losing out in that scenario. So he wanted to start riding regular public transit. He had never done it before. He has a verbal impairment. He has cerebral palsy, walks with a cane, those kind of things. But he wanted to do it. So we outfitted him with smart technology, with a smart watch and a phone, trained him on how to use it, and he started riding the bus to work, to different activities. Well, it turns out after a few weeks, the bus broke down. And if you've ever been on a city bus that breaks down, they have everybody get off the bus driver gets back on, locks the door, and waits for a tow truck. And you're kind of on your own. And so because this individual was trained, he was used to using technology. He wasn't afraid of communicating. His staff were available with him, used his smartwatch, connected with the staff. They knew where he was at because of GPS. They knew what transportation options we had to put in place. They were able to call an Uber, get him where he needed to be, and then he rode typical transit on the way home. He wasn't afraid to get back on because he knew if something bad happened, he'd get back on. And each one of these little scenarios, each of these successes are happening at LADD every single day. People are more engaged, they're more independent, and really the way we're changing services is different for each person, but it's changing the way we do everything. So again, a new service model, combining smart home technology, and that can be anything from lights. It can be things like Alexa, turn on all the lights, or turn off the lights, or when you get up at night, having motion sensors that have fall prevention lighting to prevent falls. It could be a sensory room or sensory technology in someone's bedroom, where if you're feeling stressed out, you can go into a room, push a button, and the blackout curtains come down, and music comes on, and lights you like turn on to help you calm down and relax. So if you're feeling depressed, the opposite. It gives you nature, and it gives you like aromatherapy. But then there's also different things like camera technology, so that we can see who's at the door, fingerprint doorknobs, something that's really a cheap piece of technology, a deadbolt that uses a fingerprint rather than a key, changes the way people live. Because if you have a physical or a visual impairment, a key is a huge barrier to you. It's hard to get it in the lock, you lose it, but your fingerprint never goes away. So these smart home technologies combined with community clusters, so staff are always close by if needed, and then the wraparound supports, so the staff are always available. So 24 hours a day, staff are available. If you push a button, they're there, and they can provide support. But they're not just waiting for the call. Remember, they're going to be there to proactively give people the support they need. And then taking all this technology that when someone leaves the home, it goes with them. And as we move to this new service model, it's going to allow us to provide services to more people at a lower cost with higher outcomes. So I'm really excited. I'm grateful that I was able to share this presentation and share a little bit about what LADD is doing, and to really give an idea about how, when you think about where should I go next, and if you're thinking about, okay, I'm someone who's either running an agency or a director of an agency, or even if you are working in a healthcare field, if you're a funding source, if you're a regulatory source, think about how could we be of assistance to help. So if you're running an organization that helps fund services, think about how you could be maybe a little more flexible in changing the way you look at technology-based services. I know in Ohio, even though we are a tech-first state, we still had to change a lot of the way that we do services. We've had to talk with our local Medicaid offices, our local funding sources, and explain to them that it's not medically necessary to have a lot of this technology. And so we're not going down that route. Where we're going down is how do we use enabling and assistive technology to change the way someone delivers services. So be open to those ideas. Be ready to make changes. Be flexible. Also know that it's not always perfect. You know, when we had the smart home wired ready to go, we have a backup generator. We have backup internet sources. The first time the power went out, I happened to be at the house. Power goes out. 3 seconds later, power comes back on, but the systems didn't kick back on. And what we found is that when they wired the house, they wired everything to the generator except the one plug that was actually running the servers. And so we learned that, we fixed it, we went forward. We learned that through technology. If you're not living in it and using it, the technology that comes out of the box, if it doesn't ever get updated, is not useful. And so people need to use the technology, learn how it works. And so my advice is jump in, get started. Feel free to reach out if you have questions, if you want to know where to start. If you want to put your name on our list, and when our toolkit is ready, we can start getting it out to people and start helping provide this level of assistance that people need. And really think about how do we change things, and not just say, well, we're going to try to recruit better. Because I can tell you right now, there is no recruitment scenario that's going to get us out of this mess. We are not going to recruit our way out of it. It has to be done by looking at delivering services in a totally different way. So thank you so much for having me. I really appreciate being with you. And thanks, Ray and Open Minds, for having me share what we're doing here at LADD.
Thank you, Brian. Appreciate that. I have a couple questions if you've got a minute or two, you don't mind. The first is, the finance guy in me is already thinking I need to plot this out years in advance. How much does it cost for the average set of needs for the consumers that you had? What's it cost to create a smart home?
So it's really not as expensive as you may think. So there's kind of two ways to look at it. One, almost all of our technology is retro. You can put it anywhere. So you don't have to tear any walls down. You run almost no wires. Like I said, it's all done through Wi-Fi, batteries, double-sided tape. Really, for about $11,000, you could have the technology in a home that really provides almost all the level of service you would need. Also, in most cases that we've seen in Ohio, 90% of that we are able to get reimbursed through the waiver, because it's all providing valuable, enabling technology-based service. And so it's not as expensive as people may think. I mean, things are what we did is we looked at how do we make it as affordable as possible using the best technology. So a lot of the stuff we get are from, you know, we got our smart fridge at Costco, we got the smart toothbrush at Target, we get a lot of our sensors off Amazon. It's not the technology, it's how we found a way to use this technology together to provide the service. And then when you think about the change in delivery, so if you have typically a 1-to-4 service delivery model, this is for you finance guys out there, and you switch that, and if you can keep your reimbursements in line to a 1-to-20 or 1-to-30 model, then you have instant savings and efficiency there as well to provide more services, to pay people more as well.
But I hear a lot of my providers saying, wait, those staffing ratios are in state regulations, and the regulators will guarantee that I have that there, even if it means burnout and people doing overtime. I have to have that ratio. How did you get that waiver from the state?
We went directly to them and we said, you have this built in there, and if you have a better solution, we will gladly use it. But until you do, we need to do something different. Now, we started with a pilot that gave us some data that showed that it worked. So our first smart home that we had was not licensed. It was a private pay model. It was done through private foundation money, and it was to show that it worked to collect that data. And I can tell you right now that if you're seeing that and you're getting that pushback from your state, the state of Ohio is more than happy to talk to your state. They are anxiously engaged in talking with other state directors to explain the benefit that they're seeing, because they see it as well. And what the difference to try to change their mindset is it's not that we're going from a 1-to-4 ratio to a 1-to-20, and that 20 isn't really doing anything. They're still there involved with the individual. And 1-to-20 is really when most people are sleeping. That's our overnight ratio. When it's busy and things are happening, like in the afternoons or the evening, it's like a 1-to-10 ratio, depending on the level of need. And the idea that we're not removing staff from the scenario, we're just changing the way that they're interacting, they're still there. They're actually there more often just through a virtual means. But that's where those discussions with your state agencies have to be happening, or with your funding sources. So if you have an MCO or regulation, start having those conversations, start changing the way they do it. And like I said, the state of Ohio has been more than welcome, and I've asked them to make sure that I can still say this, that I can connect your person with them and their people, and they can explain how it works. And if we started having those conversations, we've had them with a few states, and it's been really eye-opening for them, because your state agency, I'm a provider. They may not believe what I'm saying, but to hear it from my division director to division director, that's a really impactful discussion. Now, we are also working, one thing that I didn't cover, we are developing with RDD Council a tech-first waiver system as well. So developing the framework for a waiver that could be used in Ohio and then mimicked throughout the country that is specific to a technology-based service. That includes the technology, the service delivery, the ratios, the funding, all of that. So we are in the process of doing that. Anyone that's worked in waiver development knows that that is about the slowest possible outcome that you could ever go through. So it's not something to look forward to now, but in a few years, that's what we'll have available too. We're working with our state, we're working with Anchor and a few other states to try to develop that as well.
You are not concerned about the problems of training the person served to use the new technology? Has that been as successful?
Yeah, it's been more successful than we thought. We thought we would have to ease them into the technology. Now, depending on their level of need, it takes a little longer. And what we typically do is when we move someone from a non-tech-based delivery to a tech-based delivery, we do overlapping service for a period of time. So they'll use the technology and staff may still be in the home, and they just kind of overlap. Now, one is obviously not billable, because that's, I think, the definition of Medicaid fraud, but it is a stopgap, and it's something that shows here's how this works. What we've also found is that training was hugely lacking in this space. So we've worked with some training experts with a technical writer to develop trainings and webinars for individuals who are receiving services, staff delivering services, agencies that want to deliver the service, and families who are going to be interacting, so that everyone has their own specific type of training or webinars they can go through to really understand it. And then it's just using it. The more we can put it in their hands, the better it is. This idea that people can't use technology is a misnomer, because most of the time they just haven't had the option.
Well, thank you very much, Brian. It's been an exciting discussion, and I truthfully think this is really right now the very first steps towards a new technology-based solution for what seems to be an almost insurmountable problem. Stacy?
Well, thank you.
Yes, thank you, Brian, so much. It's unbelievably just fascinating and amazing, and the outcomes are excellent. We will actually be following up with this session with an executive brief, and Brian has promised to share some of those specific outcomes. So keep an eye out for that. I do want to thank you again for presenting today. I also want to remind everyone that today's presentation was recorded, and the entire presentation deck will be available for download and on-demand viewing on the Open Mind website starting tomorrow. The Full Circle Elite Executive Roundtable series is also available on demand as part of the extensive Open Minds library. I also want to just bring to everyone's attention that we do have the Open Minds 2022 IDD Executive Summit, Innovations in Care Delivery for Consumers with IDD and Complex Care Needs, that will be held June 14th in New Orleans, Louisiana, and that is part of the 2022 Strategic and Innovation Summit that we will be hosting June 14th through 16th. So I encourage you to register both for the IDD Summit and for the Institute in June. And again, we do have our full list of upcoming roundtables on the Open Minds website, and over 85 on-demand roundtable sessions under the Executive Roundtable page of events on openminds.com. And on May 12th, we'll be hosting Dr. Liming Lee and Mr. Wayne Young from the Harris Center for their roundtable session, moving from a compliance-focused program to a culture of quality, the Harris Center case study. We invite you all to attend that as well. Again, thank you both, and have a wonderful day.
Thank you. See you, Brian.
See you. Thank you.